And now, without any further delay, I would ask Louis to first to present the case. If I could have the slides, please. Slides of the case. Okay,
Okay,
Louis, go ahead.
perfect. So it's a 73 years old male, and lost the.
We need, okay,
Okay, it's a 73 years old male. He has a current ACS and stable engine. She has a particular story here, Ricardo. He has a on-flight. During on-flight, he was traveling from Toronto to United States, and he has on-flight a acute chest pain.
okay.
So he has to land on on ground to be how can I say receive support, medical support, and he come to our emergency room. So he got back from to Brazil, and just this week, about yesterday, he got admitted on our ER with the current ACS unstable engine. He has previous hypertension and dyslipidemia. Oops, I think I
Next. Okay.
next. The medication he has using aspirin and clopidogrel, atorvastatin, and allopurinol and metoprolol. There's normal renal function, and he did an echocardiogram with a preserved LV function. His rest EKG is normal, didn't seem to have any disturbance. And from the angiography, it's a pretty normal RCA here, Ricardo, that would cause our attention. If you look at this angio, you will probably see that's normal. We didn't see any narrows, no lesions at all. But when you go to the left system, just on the aerial view, you can see somehow a little straining lesion up into the left main. When you go to the aerial and the caudal view, you get the impression that it's a straight lesion through the left main towards to ostium of the LAD and somehow the ostium of the circumflex. And there's two marginals from the circumflex that comes right up across the lesion. From the you can see also a straight lesion in the LAD from the mid portion. Here is another view from the mid portion from the LAD and the left main. And when you go to the spider view, you can appreciate the how much severe the lesion is from the left main towards to the left to the LAD and somehow to the left circle to the circle, and with the preserved LV function.
Okay, so maybe we can stop here. Very, very interesting case. So this patient, a week ago, was in a flight.
Yeah.
He had acute chest pain for the first time, right?
Yes, yes.
Never had anything before.
just during the flight.
And then he had some medical care. He ended up coming back to Brazil, and he presented here with another episode of chest pain. He was hospitalized with ACS unstable angina. Interestingly, when we see this, the angiographic study, which was done yesterday,
Yes.
we can see it looks like for me more like an ambiguous lesion in the left main. I'm not convinced this is a very severe stenosis, but you see is somewhat disproportional to the proximal LAD, which is like a 4-0 vessel.
Yes.
Proximal circumflex like a 3-5 vessel, and you see a relatively small size left main.
Yes.
It appears to me, if you can go back one,
Yep.
the cranial view, it looks like a severe stenosis in the mid LAD, and now move to the spider again. And now we are in a situation here that you have this ambiguous lesion in the left main. I see some disease in the proximal LAD as well, looks like, and also in the proximal circumflex is definitely some disease, but again, not very clear how critical it is.
Yes.
So in a case like this, Louis, this patient technically is like a multivessel disease, right?
Yes.
Can we feel very confident that we can see a culprit lesion here for his acute event, or everything is a little bit, let's say, a little bit ambiguous?
Yes. It's cloudy because you see, if you apply Finesse laws, you can somehow say that it's a pretty tight left main. But I don't know if you have the left main would probably be the culprit lesion. You also have somehow from the mid portion from the LAD, you have a street lesions too, a severe lesion. That's hard to define. If you go to the how can I say the rest AKG, it's pretty normal, né?
Yeah.
So you cannot say by the findings from the angel and the clinical findings that he has. You can, how can I say, know who is the culprit lesion from this case.
So in a case like this, it is applicable to consider physiology imaging, or you feel already confident enough to say, no, I have to treat this and I'll target first what I think it's a worst lesion.
Yeah, you can. Yeah. Physiology would good, but from this case, you have a, how can I say, a severe lesion from left main. So if you
So you're confident it's severe lesion?
Yes.
Okay.
I am confident from the angel that it's a severe lesion.
Could you
from the
demonstrate that? I know last week we demonstrated here the angio-based physiology, the MFR, a very, very interesting system that you can do it by angio. Very easy to do it. Could you demonstrate that? Can we do it this like online now?
Yes, I'm going to do this.
So maybe again you can assess the LED plus the left main and the circumflex and see what it shows.
Perfect.
So can we have here in the screen, the MFR, the physiology, please? The output from the physiology. Okay. So Louis, maybe you want to show us here the step by step how you can do this analysis.
Yeah, so you are on live, so you can see on the screen that's all the frames that we got from the
okay, so Louis here. Okay, so we can show you here working. Okay,
I'll be just you're showing my back. So this is all the angel that we did on screen live.
We just
now.
did the angel here. We just acquire.
Yes.
So the computer, it's already this platform is already integrated.
Yes.
With the hospital network.
Yes.
And we can have we are actually working with this in all the rooms in our cath lab right now.
Yeah.
And you select and what do you do?
Yes, I can select a previous exam, but we can select the live case now. So all the angels are here on screen. So I'm going to pick up the how can I say the first angel, that's the area view with the caudal view.
Okay.
So we are just trying to see the vessel type. There will be the LED, the circle on the RCA. So probably
the RCA.
The RCA
is important to select.
Yes.
Okay.
Yes. So there will be the LED or the circumflex to confirm. And there's the angel. So it's he's just yes, he just did the, how can I say, the automatic vision from the lesion.
So is a automatic already?
Yes.
Detection of the vessel contour.
Yes.
And now I see the detection from the left main to the circumflex, right?
If you see there's a red, how can I say red? I don't know, a yellow line that how can I say that shows who is the which vessel you are trying to acquire the image.
Okay.
And
so you previously select LED or circumflex, and then you can go straight. Okay.
Yes. So if how can I say, we can let's see if you can show the.
And you can move the cursor here.
Yes, you can, and you can see what frame do you think is the most reliable to do the.
So this is like based on QCA, you should have one end of diastole.
Yes.
You should avoid overlap. You should have straighten the vessel, right?
Yes.
The best possible view. Okay.
Exactly. Just say perfectly. It's like the QCA. So I'm setting this as the keyframe here. I'm gonna confirm.
Okay.
And I can lock the path line, so I can choose which part of the vessel I want to.
So you can navigate throughout the vessel.
Yes.
And,
so
and you can put your segment of interest.
Yes.
Okay.
I'm navigating proximal to the left main.
Okay.
And you can see you can include the left main.
Left main hold. Okay.
Yes. Okay.
Yeah, I was curious about that because you said LED.
Yes.
Or circumflex or RCA, but you do have a possibility to include the left main if the lesion involves the left main. Correct.
Yes. Perfect. So I can. I'm going to zoom here the image here.
Okay.
And I'm just going to navigate so I can. How can I say? Do corrections from the.
If you have to edit, you can edit.
So,
okay.
You can show all the corrections. So I'm navigating through the vessel.
I like
here.
the contour. Yeah.
Yes, I'm like yes.
And you are inside the cath lab, right?
Yes.
Inside. Okay.
Yes. And now here.
Okay. So can we see the results?
Yes, I can see the results. And if you wanted to, you can add some
side branches.
Yes.
Okay.
But now I'm going to click
Yeah.
next.
I remember the previous versions of system like this could not do bifurcation. So now this system have evolved,
Yes,
and now we can have bifurcation, which is a great
I'm just doing the calibration
advance.
from the
And you're
catheter.
calibrating, okay?
Yes.
So you can calibrate, okay,
Yeah.
anytime.
I'm going to do next now, and he's going to do the. And now the computer is doing his work.
Okay.
It's work.
Okay.
Okay.
And
He's
it shouldn't
computing.
take that long.
Yes. And it's pretty fast here. The analysis.
Okay.
And
So
now
okay.
perfect. So it's 0.75 here, at this point here, and I can add some branches here.
Okay.
Ricardo. So let's see. I can click here.
So
and
I can see the first branch is like 0.61
Yes.
because it does have a lesion in the ostium plus the proximal lesion
Yes.
in the entire vessel.
Yes.
So
He's
it's taking
adding.
the full
Yes.
coronary tree. Oh, this is
Adding here. So
amazing.
another branch. So now
Yeah.
what have we done? The FFR at the distal portion from just come through from 75 to 0.62
Okay.
because I add some branches and all the myocard territory that's on
Okay.
risk hence adding from
Okay.
the
No, this is really beautiful demonstration on time, very fast, and we can see how does this system can help us for decision making, as you already identified that's a significant ischemic inducing lesion in the ostium, the circumflex, the lesion that extends, at least by angio, extends
Yes.
from the left main to the circumflex, and plus you do see significant impact in the branches, maybe because of the proximal
Yes.
lesion,
Yes.
but we can also treat, and then you can do the analysis at any time you want to make
Perfect.
decisions throughout the procedure. So
Yes.
you can really guide the procedure with the system.
Yes.
And that's, I think, very
All
important
live,
information.
all live. Okay.
Okay, so maybe you can have back here the camera into the with the operators. Okay, and now we can have also the angio to show the angio. Okay, so Rodolfo, I know you're already working here. Just tell us what have you done here. So we have the angios that were acquired today. So you can see the first angio.
Yeah, you can see the severe lesion left main.
So it looks like, I think this is more evident that's a more severe lesion, right, in left main.
Correct.
And also the ostium circumflex calls the attention.
Two
Do you think that's
ostium and ID too.
yeah? Do you think that's a lesion also in the ostium of the LED?
I think so.
Also extend, right?
ostium, yeah.
Not so severe, right? Doesn't look like
Yeah.
to be so severe, but
Some of these
okay. So
severe.
next one, next angel here. This is a cranial view. So that's a lesion. It looks like a severe lesion, right? In a mid LED as well.
Yeah, about 7%.
About 70%, agree. And here, that's a left main. And this, what type of guiding catheter are you using?
I'm using a extra backup 7 French.
EBU 7 French, okay,
Yeah.
EBU 3, right? So really, we don't see too much back of flow here.
EBU.
It looks to be a fully diseased left main, but with a good pressure throughout the procedure. Maybe we're gonna show here
It's a 3.5 by 18 stent.
the pressure and the EKG tracing here. And I see, so you decided to go ahead and treat the mid
mid
lesion
portion.
already.
Yeah,
Okay.
yeah.
So which stent is this?
It's a 3.5 by 18.
3.5 by 18. Okay. So
And
your decision here was to
postulate
first treat the mid LED with a significant stenosis, okay? And this is the final result. And I see you have done IVUS. So what's important here, Louis, to do the IVUS when you have this type of anatomy, bifurcation, to see the full extension, involve the left main, different diameters, is always important to have some more information. So can I have the IVUS in screen? And we're gonna see what we have learned by IVUS here. IVUS imaging in the screen. And then we're gonna come back to see what they're gonna do in the left. Okay, so I'm coming here. We have done first an analysis of the final result with the stent implanted in the mid LED. So you can see here is about the 3.25 by 3.5 vessel with some diffuse disease. After that diagonal branch, we see here the stent implanted. So it looks to be well opposed and expanded. And this is proportional to the vessel size. No signs of incomplete position at proximal end due to the post-dilatation that was done. So this is great. Now, as we move here to the proximal LED, we can see, and I'm moving here with my hands, this is where, after a septal, that's where disease starts, calcified plaque, no significant compromise at this point, but we come in here very close to the osseous, so I'm showing here the very proximal part now of the LED.
Espera um pouquinho fazer ao vivo.
That's where the osseum comes. And I have to say this is more disease than what appears by angio, right, Louis?
Yeah, perfect.
Yeah.
It's more
If I could
severe
do
than
some
we
measures
thought.
here. It's still above 4, but it's definitely some more significant disease if you compare to the real vessel size. And here is the distal left main. You can see the circumflex wire coming from 4 to 5 o'clock. And this is the distal left main. At this point here, looks like to be a more focal lesion. And we can do some measures here as well. So about 3.9. And the lesion, I can see, as I mentioned, is more focal, but I do have a disease left main up to the osseum with a calcified plaque, a calcification that we see also by angio. We also did the run from the circumflex, and here, this is about the 3, close to a 3.5 S at this point, calcified plaque, and as we move to the very ostium, that's LED coming here, wire from 12 o'clock. There's also a very focal, more significant disease at this point. And if we have done some analysis, very, very awesome location, about 2.27. So Rodolfo, significant disease in the left main, this is very clear. Significant disease in the circumflex by both physiology and by imaging, and also a lesion that extends up to the ostium of the LED. So what's your plan here?
My plan is use 2 stents. First in the left circle, and then LED with a nano crush technique.
Okay, so your idea is to go for 2 stents strategy, and you're going to do the nano crush technique. So tell us what you're going to do now. So we have a wire. Can I have the angel? Okay, we have the angel. And we don't need IVUS anymore. So we can have just the pressure, the polygraph here. Okay. So you have a wire in the LED, you have a wire in the circumflex, and you have a wire in the
first marginal.
Marginal, okay.
Yeah.
And now you have a balloon position.
3.5 to predilate.
Okay, to predilate the os of the circumflex, so 3.5. And I'm sure you're going to pull a little bit, the pull back here, a little bit the guiding catheter. So Louis, what pressure? 6? Okay.
10, 11.
Up to 10.
Up to 11, so you're doing more good lesion preparation
15.
to advance the stent.
Okay. It's okay.
Okay.
Deflate.
So
Não teste.
balloon here,
Let's just
control
do
angel.
some tests here.
Okay.
Everything is fine, okay? Pressure is a little bit down here.
Okay. Some dumping.
Pressão. Okay, so now it's back. That's some dumping out of guiding catheter, as you would expect, a disease. And here you're advancing now a balloon into the
LED.
left main to the LED, right?
Right.
To predilate as well.
Okay.
Okay.
Perfect.
Só 6.
1, 2, 3, 6. 1, 2, 3.
Ok? Escorreu.
Okay, so slip a little bit, that's
Yeah.
some calcification.
Yes.
And then you're gonna advance the stent, right, Rodolfo?
De novo.
Yeah, just doing another kissing
Okay,
here,
just,
Ricardo.
and
Up
then
to
you're
6.
doing like a kissing, okay?
Oops.
Ok?
Okay, you can see here
Great.
the narrowing. So some reaction here,
Yeah.
and pulling now out the balloons, and then you're gonna advance the stent. So Rodolfo, which stent you're gonna use here? A 4.0?
Tá 4 18.
4.0 by 18, okay?
Here's some angle here.
Pressão.
So some control angle,
Okay.
the pressure is okay. Okay, everything's fine. So when we're dealing this very sensitive location, have to be very
O stent na...
concentrated here. So your idea, Rodolfo, since you're going to do the nano crush, go with stent first in the circumflex.
Perfect.
Which stent?
3.5 by 12.
Ok, so
Patrick, please.
stent 3,5 por 12, por favor. Já está com o stent?
Tá aqui.
Ok, já temos aqui. Okay, so a 3.5 by 12 stent is going to be advanced into the circumflex. And I think, Rodolfo, that if you decided to do the nano crush, the angulation is favorable, right? It's like almost 70
Correct.
degrees. I mean, 90 degrees. And you can do really, really just enough to cover the ostium, right? Without compromising or protruding too much into the main vessel, left main to the LED. I think that's a favorable anatomy for this particular technique. But also other techniques could be used, right? The regular DK crush or colot, right?
Right.
Do you think colot here is a good idea?
In this case, it's okay because the ocean of the LED is not tight.
Yeah. So could be the preference,
to
right?
recross.
Could be the preference
Yeah.
of the operator and experience.
Perhaps because
Okay.
we have a, how can I say, a really short LF main, Ricardo. I don't know if Colot would,
Yeah,
would be,
could be
easily done here.
time consuming and
Yes.
a lot of work, but can be done. So 3.5 by 12 stent in the circumflex, and you already have a balloon
Yep.
that you have to park, right, Rodolfo, to do this technique, right? You have to do the balloon in the LED as well.
Yes.
So minimum protrusion just at the edge of the ostium to cover the ostium, and you have to do some
Spider view.
Yeah, I got
Uh,
the spider here.
very important, Rodolfo, to go to a
Change
different
the-
view, right? Change view to make sure you're in the right position. Spider view, it's where you can really see the takeoff of the circumflex. So we're moving here. Pressure. And pressure is okay. So yeah, you see how this view really shows the bifurcation of the left main. So Rodolfo, it's positioning here, and we're gonna do some control angle to make sure we are in the right position here.
Yeah.
Okay, so maybe pull a little bit, right, Rodolfo?
Yeah,
Just to be
little
at the ostium location.
Okay.
Okay, so now control angle. Okay,
Little bit.
A little
have
bit.
to pull back a little bit just to be at the ostium. Okay, test. A little bit more. And have to pull a little bit the balloon from the LED left main as well. Puxar o balão um pouquinho, né, Rodolfo?
Yeah,
Okay.
I think.
I think that's a good position now. Okay,
Okay.
I think that's a
Okay.
good position. So Luis is going to deliver the
Devagar.
stent here,
Yeah, the stand here, I'm
Yeah.
going to.
and all of these implants should be very fast, shouldn't take too long.
Here. Now.
Okay, so
Up to 80. 8.
8, okay, 8.
Okay.
Okay,
Deflate.
you can show the operators here. Okay, it's good. So stent in the circumflex has been implanted,
Olha aqui, ó.
covering
Yep.
the ostium. So Rodolfo, now you can do a post-dilatation with the same. Okay, so you're just making sure that no
Right.
protrusion.
Okay.
Now Rodolfo is pulling here the balloon from the circumflex. Maybe
Yeah.
that's a
Pull
point
back.
that you can do a
Yeah.
kissing here,
Yeah.
right?
1, 2.
Very fast
Safe.
kissing.
1, 2, 3.
Okay, so it's a first kissing. So this is a somewhat modified decay crush. Standard decay crush. It's a nano crush.
Oops.
Okay. So the stent is there.
And I can do a.
And I think with this technique, with the good positioning, you can go, you shouldn't have any problems to advance the stent in the left main into the LED. Okay, so
Let's do an angel here.
control angel. Okay, I think the very good position. It's difficult to
Yeah,
to
to inject the,
Two balloons.
the dye because
go
you have two
with the
balloons.
die because two large balloons inside. So Rodolfo, which balloon, which stent you gonna go now with in the left main LED? A 4.0 by 28,
No.
23.
Shortly. 22. Tem?
Ok,
22?
so
Ou
stent
18?
4 por 22 ou 23, por favor.
Tem 18 aí, né, também. Tem 18. 18.
Okay, so Rodolfo's gonna go to the short 18, which is enough by what we saw by IVUS. And now they're bringing here out the balloons. And Louis, at this point, I think this technique, what is very helpful here, is that you have the advantage to have patency of the side branch without the need to recross. Of course, you need to recross to optimize your result, right?
Yes.
But there is already a stent there. You don't have the risk to lose this side branch or have some difficulty to the wire because of the angulation.
Yes, it's a.
Or if you have a spasm or dissection or anything there,
Yes.
is a very large circumflex. You showed the physiology, so it's significant physiology. Not every time we see a lesion in the circumflex, even a significant lesion in the circumflex that causes
Yes.
ischemia, right?
Yeah.
So here, I think it also calls the attention.
And I think, Ricardo, because it's a safe technique. You get how can I say you get bit patient, and you have to, you don't have to be so worried about losing the side branch.
Yeah,
or
yeah,
recrossing
special
it.
large side branch, yes.
Yes.
Okay, so of course you should follow all the steps when you do a complex technique like this, especially on the left main. So now Rodolfo is advancing 4.0 by 18. So Rodolfo, are you going to keep this view or are you going to go a different view now?
Finally,
Because
position.
you want to go up to the ostium, right? Ostium
Yeah.
of the left main.
Vamos tirar os pias.
So
Pull back the. Oops.
and also it's a good idea. Also, it's a good idea to remove the wire from the circumflex, right?
Yeah.
And we saw how easily the stent was advanced. So
Because of
removing
the
also
crush.
the wire.
Yes, we did the crush.
Exactly. Exactly. If you were too protruded without the kissing, you could have problems here. So Rodolfo basically removed the wires from the circumflex because you don't want to have wires in between metal, in between stents. LAO cranial view is always a very important view, and I would say the last view before you implant a stent that you pretend to cover the ostium of the left main. So Rodolfo is advancing the wire, and in this view he can make sure that he's going up to the ostium.
And in this case, the calcium, the calcium.
The calcium also helps you, right? The landmark
It's a marker.
by angel. Yeah, very, very nice point that you made. Yeah,
Okay.
I think you're just there.
Okay.
I like the position. Okay, so the calcium help. So Luis is gonna deploy the stent. You have to be fast here.
I want to deploy. Oh,
Okay,
Dash.
so
Ops, peraí. Devagar.
yeah, you have to just make sure that you're in the
patient
right position.
breathe.
Avoid big breath here.
Testinho. É só
Troca o
basicamente-
contraste, por favor.
Testinho.
Vamos lá.
yeah, the test here. I'm just going to
Não teste.
try
Que...
some dry here.
Patrick, quando pedir sem sulfo.
Okay.
No.
No, let's do some tests here because it's a.
Okay,
Do
we're
the
gonna
atmosphere.
test here. You
Yeah,
have to
yeah.
make sure
Do the
that you are in the right place.
Da atmosfera, duas, só duas. Teste.
Yep.
Feche. Feche.
Well, let's pull back a little
Plate.
bit. Oops.
Okay, so avoid big breath.
Deixa em 2, só
Okay.
solta, teste.
Yeah,
Okay,
perfect.
acho que foi okay. So
Perfect.
we got the position.
Okay.
Yeah.
So we go up to
10.
10 atmospheres.
Enough.
That's enough.
Yes.
Then we can change here the view, and you can also use this balloon, right, Rodolfo, to post dilate and to do like
I
sort of like
back
a
a little
pot
bit.
here.
Yeah.
Ok, inflate de novo.
Right to the aorta, and you can do
Okay.
Ok, mais.
pulse dilatation.
12.
Oops.
Yeah.
Ok.
14.
So high pressure. So 14, deploy with 10. There's a 4.0 by IVUS. Now you went to 14, and I think you're just in the perfect position there. Let's see by angel.
Yeah. 1, 2.
Control angel. Oh,
good.
beautiful, beautiful. I think excellent positioning. Patient is very stable.
Não 4,15
Pressure is
depois.
okay. So now, Rodolfo, what are the steps? Do you decide to post dilate? First they stent in the LED, then you do a pot, or you
Then
try already to
recross.
recross the wire into the circumflex.
First
What's your
postulate.
recommendation?
First, postulate.
So okay, so
And
first
recross
post dilate.
After postulate.
They stent in the LED. Remember, you don't have wires now in the circumflex, but you do have a patent circumflex, and I think that's a beauty and potential benefit of this technique. So we're going to go with the 4.0 by 15 NC, balão não comply, balão de pós 4.15, por favor, ou algum similar.
15, 12.
And o guia também, wire maybe you have to go down a little bit.
No,
Okay.
okay.
So we have here balloon being advanced now, and you don't have to worry. Circumflex patent, that's a stent there. Just optimize.
The two marginal open through.
Two marginals are open. The vessel just work in the main vessel. Do what you have to do. You can even do IVUS, right? Do a control IVUS, make sure you have all the expansion there that you want, and then you're going to deal with the bifurcation. So,
Balão 4,5 para o tronco.
Yeah, balão de pós 4,5 por 6 ou 8, por favor. Pode abrir.
Pode.
So this is a 4.0 by 15. Always fast,
because you don't have ischemia from the left main.
Yes, always to be fast here when you post dilating.
Yeah.
Fast dilatation, that's what I was trying to say.
4.0
So 4.0 by 15 up to
27.
27 atmospheres.
High
So
pressure.
very high pressure, and you feel confident because you have the IVUS, right, and you know the real vessel size. So that's important. So now you're going to do with the pot, and you're going to go with the 4.5, right? You decide 4.5, short balloon.
Pot.
Even though you have room outside to the order that you can basically fit any balloon there. But which balloon is this one? 4.5 by 4.5 by 6. So, okay.
It's a short.
So optimizing here, doing the pot, and the pot has the same effect that you do a pot for provisional, stepwise provisional approach. You're going to be able to fully oppose the struts into the proximal segment of the bifurcation at the carina. And also that gives you some scaffolding to the osseo, the circumflex. In this case, you're basically opening the struts at the level of the bifurcation and towards the stent in the circumflex. So the patient is under sedation, so that's why sometimes is uncontrolled breathing here. Okay, high pressure as well. Can you show here? Okay, so
20.
Vai 27.
Oops.
Okay.
Deflate.
So
Again?
then you're going to bring to the otrum, right, Rodolfo? Yeah. So at the carina, you can see exactly where you are. So high pressure as well.
Okay.
Okay.
And then now.
And just to do the flaring here at the osteum. Okay. Okay, also high pressure. Okay, down. So control here to make sure you have everything in place.
It's just removing the balloon here. Ricardo, we're doing the angel control. The
Yeah.
control.
So if you like the result here, then you can recross right to the circumflex,
Perfect.
and you can do your kissing and finalize your procedure.
Yes.
So
Here we're doing the angel here.
aqui.
1, 2.
Guia tá aqui, ó. Pera aí.
guia Pilot 50, por favor.
Tá aqui. Já
1,
tem.
2.
Certinho?
Oops.
Okay. Oh, this is beautiful.
Beautiful.
Wow. This is
Oh.
amazing result. Amazing result. It's fully reconstruction of the bifurcation carina. If you compare the pre and
I will
post, it's
try.
really, really amazing.
You can see
Recross
So,
distal.
which wire are you going now,
It's a
Rodolfo?
pilot.
Okay, so you have
The same one.
the same Pilot
Yeah.
50. You're going to try to use the same wire. Sometimes you have to try to use a new one to have a better tip. But if you can use the same, you can save a wire.
you can see how
So-
large is the left main
So
here.
Rodolfo, I have done some bench studies and also animal models, and it looks like when you're using this technique, even though you don't have like a real crush here because you have a nano crush, what do you recommend? Try to recross by the mid cell or distal
Distally.
cell. Does it make a difference if you use
Yeah.
two stents?
Yeah. If you can.
I like the mid cell when you use this
The
technique.
mid to distal.
Yeah, mid to distal, I would say, but not proximal, never proximal. But I think mid, you can have a better distribution here of the
Yeah, the struts
of
from
the
the
struts
yes, from the
forming
stand.
the new ostium, right,
Yes,
of
yes.
of the side bench. So Rodolfo is working. I think he's already inside, but not being able to move distally. Okay,
Yes.
now, okay, very good. And the pot, of course, very helpful here. So Rodolfo, you're gonna go now to do a kissing balloon. Do you think you should first open the cell here
Balloon.
with a short balloon, a 2.0 maybe,
No, I think
or you're confident
2.5.
to try to go?
Well,
Ah,
2.5
with a larger balloon.
Okay. 2.5 balloon.
I
Okay.
can try with the 3,5 que a gente tem, 15 aí. 3,5,
Okay.
15.
So
The
you
same.
want to try with
I'm
a
gonna
larger
try with,
balloon already to
The same.
do the dilatation, right? To the dilatation.
The 3.5 non-comply.
Yeah. So Louis, I was going to tell you, once we are working here, could you show again the MFR
Yeah.
with this control angel
Yes.
to see what's the result now?
Yeah, we can
Okay.
show.
So can we have the screen now? In the picture in the left side, we could see you could show the angel, and in the big screen in the right side, if you could show us the FFR, the physiology, please, the MFR.
Yes. Or,
Okay.
yes, the angel.
Okay. So
and then
we're
from
changing
the
here.
MFR, we are.
So instead of the angel, we want to have the physiology, please. If possible, to have the physiology. Okay.
Patrick.
So Louis, maybe you want to do the step by step.
Yeah. So just remind that we are using a guide wire towards the LED. So just how can I say? It just automatically shows the circle here. So yeah, it's pretty good here. So I'm going to use this angel here,
Okay.
and now it's computing,
Dá pra você abrir, né?
Dá uma...
and we're trying to see what will be the new. Or here, Ricardo. Let's look here. It's
Okay.
pretty good. It's 0.93, and I'm going to add some branch here. 2.
Pega um balão de pré, 2,12, por favor.
Let's delete here.
So, Louis, so what's the result now?
0.93 here, and I have to add the here. This
Okay,
branch here.
so before here was below 0.7, right?
Yeah.
If you did the final measure.
Yeah,
Now it's 0.93, so basically demonstrating that
yeah.
you achieved the goal, the objective
Yes, the
of
objective.
your procedure.
Perfect. So
That's
that's
beautifully done.
Beautiful.
What about the first and the second branches here, the marginal branches
Yes. To do it so, I have to go back and choose another frame because I think
Okay.
it's got a bit.
here. So maybe you want to show here.
What? Open.
Vamos lá.
Here.
So,
Ricardo?
okay, so just select it.
Yes, just selecting here. So I have to do. How can I say?
Again, end of the S, so you know what
Yes.
it's more ideal frame, okay?
Remember, because it's a angel test. We didn't do it
Yeah.
as an angel for the.
Yeah.
So we're trying to.
So, yeah,
Yes.
so, yeah, I like
Yes.
this one. For the first branch, I like this one.
Yes.
So let us see.
Yep.
Pergunta. So the analysis itself is like less than 30 seconds, right?
Yes.
You
just analyzing
again, we are inside the cath lab as Rodolfo is working there.
Yes, already set up. So here I'm trying to add some.
Yeah,
branch
maybe you
here.
have to do some edit in the distal tracing there.
He didn't.
Oh, okay.
Okay. So what
Well,
can
I already see the second diagonal. It looks like normal, you know, it's like 0.92.
Yes,
So before it was significant because of proximal lesion, as you
Yes.
mentioned.
but now it's normal. What we
Yeah.
have to do? Perhaps we do another angle with a little bit more
Okay,
dye.
we can
so
do
we
that.
Can, we can do that. So we can do the analysis
Yeah.
perfect.
So can you also show here the mid LED before and after stenting? Can you also show that?
Yes, I can show it here before and after. Okay, before here.
Yeah, maybe you can choose as we demonstrate here. So Louis is showing here the step-by-step to the angiography-based
Okay.
analysis
Okay, here, Ricardo, we
to
are.
show what's the pre and what's the post,
Yes.
que é um e-mail.
Não, vou pegar fazer uma âncora.
Deixa eu separar também balão 1,5 por 10. Tá?
Puxa.
Ok.
So, analysis again the previous before we do the stent implantation here, Ricardo, and the computer is already making the okay. So
Agora sim.
Okay, so Louis, you're selecting here.
yes, just
That's a pre, right?
yes, the pre I'm doing again.
Yeah, so maybe I could have the image here in the computer, the station that we're doing here, the FFR analysis. Can you show us here the camera? Can you show us the camera here? Okay, here we go. Okay, I'm here. Okay, okay, very good, very good. So Louis, where are you now? You're doing the pre, right?
Yes, I'm doing the pre.
Which was significant, as we
Yes.
mentioned. Okay, so basically doing again, and you
Yes.
want to do the final, right?
Yes, this is the again. This is 0.7. I'm trying to add the branch here.
Yeah.
And
I
the
remember
final.
did some editing, and then we had the final analysis.
Yes,
Okay.
the final is here, Ricardo. I don't know where to put the final here is here.
Okay. Can you also show the LED, as you said?
Yes, I can show.
Yeah, the pre and post stenting.
Yes, I don't know if the pre, but
Yeah.
the post, but
Yeah. Of course, we treated the left main here, but
yeah.
maybe you want to do the pre, and
Wait.
then after Rodolfo acquires the image, we do the
Yes.
post.
8,
So it's the pre here.
So that's the pre here, okay?
Yes.
10,
I
12.
have to unlock the path line and
Yeah. Yeah, because you have a disease in the left main, right? If
Yes.
you didn't have a disease,
yes,
you didn't have to go up to the os of the left main, correct?
yeah,
But if you have a disease, then you should take all the disease segments into consideration, correct?
perfect. So
Okay. So what we are doing now, for those who are following us here now, we're doing a live demonstration of the analysis with the angiography-based
20.
physiology, the MIFR system from Pulse Medical,
23.
which is distributed by Microport in Brazil.
yes, 0.79 here.
And you see here, okay, the significance.
Yes,
And
Yeah.
then you see how he already detects the side branches,
Yes,
which is
it's
always important.
amazing thing.
Yeah.
It's amazing.
And
So what we're trying to do is we're trying to how.
so basically you have two components here. You have a lesion left main, you have a lesion LED. Can you tell us which one is more significant to the final result here?
Tem
Or basically
Tem
you have to take just the let's say the the step between each lesion.
Yes, because of the
Because I see here you can have the cursor
yes,
and you can navigate.
yes,
Can you navigate and show us?
yes.
So here,
it's like
prior,
a
okay.
pullback from the
Okay.
exactly as the FFR
Okay.
does. So you have the pullback and just what to treat the
That's a big drop of pressure.
Yes,
is.
big drop
So
here.
if I have to pick, of course, there's some limitation of the view here, but if I have to pick, the LED is the one which is causing,
yes,
which have the biggest contribution for the drop in pressure
yes.
and to causing ischemia into this anterior wall. Right?
Yes, anterior wall will be the left, the left, the mid portion, and this severe lesion on the mid portion.
And same for the also the circumflex.
Yes,
Even though there's some disease in left main, which I think it's reasonable for what we saw by IVUS, right?
yes, yes.
Of course, there's a significant disease in the left main, but it's more severe in the osseo of the circumflex and also more severe in the mid LED.
Yes,
So looks to be very consistent.
yes. Consistent with everything that we did, and we treat according to the angel too. But we're just looking forward to see the results and the final angel, so we can,
Yeah.
how can I say, we can calculate the final MFR from the both system, from also
Okay.
from the LED from the circle. But with the circle, I think it's how can I say, it's marvelous results here, Ricardo.
Okay. So we can definitely see this analysis and see how it goes. Also, it's also always a good idea to have the final imaging, intravascular imaging, to show. So I'm just going to show here what was. Can I have the IVUS in screen, please? IVUS now.
Wait.
IVUS. Can I have IVUS, please? Instead of physiology, I want to have IVUS. Okay, IVUS, please. Okay, so what I want to show here was in this run that we did before starting the PCI in the left main, just to see what did the left main looks like and how did we size. So here, there's some calcification here that show me some acoustic shadow behind this plaque.
25.
But what I can tell by IVUS here, if I take the full vessel size, really close to 5 here. If I go up to the EEM,
Wait.
okay, we don't have a non-disease reference here at this point. I would say less disease in the mid portion of the left main. Lumen here was close to 4, but I can estimate here vessel size
Pilot 150.
about maybe a little bit more here, 4.5. Here also 4.6. So we did the pot here with a 4.5 up to very high pressure, and we think that's also well planned according to the information we got from IVUS. Just to remember, the minimum lumen area at left main was about 3.9, so significant as well, but not as severe as we saw in the other vessels as we mentioned. So Rodolfo now is working, and Rodolfo, what have you done here?
The 2.5 balloon didn't cross.
Can we have
the
back
2.0
here
balloon
the angel
didn't
in the
cross.
screen?
And the
So you have to open, right? To do some extra work to fully open
I can't.
the struts, and you're going to
The
recross
balloon
with a third
didn't
wire.
cross.
Okay.
The 3.5,
Yeah.
the 2.5, the 1.0
Yeah. When you have difficulty to
didn't
recross
cross.
into the side
Even
branch,
with
you
anchor
can try
technique.
smaller balloon. You could do anchor technique that
Yeah.
you did here already. Can I have the angel, please?
Now I
In
will.
screen. Or you should remove the wire and try to get another
Yeah.
cell, because sometimes you get just one cell, right? One angulation that does not let anything go down. This is part of the business of bifurcation. So you're trying to recross here with, okay, so
First
clear
merge.
that's a different location. It's not that difficult to recross, but advance might have to do some extra work. So this is a pilot, Rodolfo?
Yeah.
Okay.
One.
And you have a wire, you have a balloon in the
150.
LED, or maybe you want to remove the balloon, right?
The balloon
So
I
don't give
used to.
any resistance there.
No, not the balloon.
Okay, so Rodolfo is working here. Can show his hands, please. Zoom in his hands. That's a pilot 50. No balloon there, so you can maneuver easier your wires into the vessel, not competing with other devices. So now it's advancing, and as you have to have more angulation
Okay.
at the tip of the wire,
Passar o balão
gives you
1.0
some
aqui.
work. So
Balão 1.0.
Rodolfo, what do you recommend in terms of the tip of the wire to recross such an angulation? It's like
It's
secondary
like
curve,
a
like
secondary
90
type.
degrees.
Yeah.
What do you
With a
recommend?
45, two curves at 45
So
degrees.
245 degrees,
Yeah,
okay, instead of
exactly.
190 degrees.
Yeah.
So one the very tip, and then one a little bit proximal, so you can have
Perfect.
90. Yeah, that's what I like to do too. So now we go into a very short balloon, it's like a 1.0, to really be able to cross and open the struts. The other wire will be removed, but first try to cross. Okay. So let's see if it goes now. So Rodolfo's advancing. Okay, so still a bit challenging here. Let's see.
Okay.
Okay, good. So change the angulation, right?
Yeah.
Change the angulation, and then it went easily.
Bud wire too.
Yeah, 2 wires, change angulation,
Okay.
you go high pressure, so it's 1.0, and then you have to escalate, right?
Yeah.
So
Two.
what's the next balloon you're gonna use? 2.0.
We have a 2.
So we already try a 2.0, so we're gonna go with a 2.0 balloon. You wanna keep the wire here, Rodolfo? The other wire?
No.
You don't have to, right?
I pull back.
You don't have to. You don't have to keep anymore. Okay, so we already removed the unnecessary wire, and now 1.0 was okay. Let's see if the 2.0 can be advanced.
So we're upscaling the
2.0
balloon size.
balloon is being advanced, and you have to escalate. And even with large balloons, you might face this, and you have to do one by one in order to advance. So this is a 2.0. Still did not go very easily, but I think it's enough, right, Rodolfo?
Okay.
Just at the awesome location.
All right. Plate.
So Rodolfo just advanced what could be advanced. Go high pressure, reposition the guiding catheter, more support. It's a good flaring, so he can work without causing any distortion Constantine effect at the left main ostium, the struts there. Trying to get more support. Okay, advancing more. So really see, it's like 1 millimeter by millimeter,
Yeah.
right,
Yes.
Rodolfo?
Looks a football game here.
Yeah, as you try to do it, yes.
Let me try
Okay, so
anchor technique.
trying to advance more here.
Sobe o outro. 8. Wait.
Trying to do some anchor here. Yep. Up. Anchoring the
Meio de palhinha.
LED. You have to be quick because you don't get too much ischemia here.
So you try to do like anchoring, right,
Yes.
Rodolfo, to advance here.
Okay.
Just a deposition, so don't keep it inflated too much. So advance a little bit more. And
Oh,
Okay.
that's
okay, so
perfect.
just slip
Left, yeah.
left in the vessel.
So Ricardo here,
You just had the
we're going
angulation you needed to do that. So can we
Going
go
to
up
do-
here, Rodolfo?
Yeah. Pode ir.
Okay, so we're gonna go just to fully open, higher pressure.
Ok. Esse é diferente. Vou dar esse flow.
And then I believe you're gonna go with the 3.5, right? To post dilate. Balão 3.5 por 12 de pós, por favor.
Tem uma na mesa aí. Pega um novo.
So we are now confident with the 2.5 that we are now will be no
Yeah.
obstructive
I
from
think
the struts from the stand here.
You rearranged
Yes.
to not have this difficulty anymore. So Luis removing here the balloon. We're gonna go now with the 3.5 by 12 balloon.
Yes.
Okay, 3.5 by 12 balloon.
Yes.
So Rodolfo, after, if we can advance here, we can do the kissing balloon. Do you recommend to do a repot? Does it make sense to do a repot in a case like this?
Yeah.
What do you think, Louis? Does it make sense?
Yes, perhaps yes, because it's a left main, and you have
Okay,
the order
you
here.
see, 3.5, it went very easily.
Smoothly.
Vai.
Smoothly.
Yes,
yeah.
smoothly. So we're gonna go first here.
Olha,
We're gonna go high
25.
pressure.
25.
Okay, so
Ok.
25, 26.
I pull back.
There's some under expansion at the level of the ostium. So now we're gonna pull the balloons together. Okay,
LED. LED flake.
LED first.
As a lady, I'm
So
going to
Rodolfo likes to do
Yeah.
Yeah.
a
Out. Isso. Agora,
Down.
Down.
one
Vai.
by one here.
6.
do. We're
So
going
we're gonna
to
go
do
together here.
simultaneous here.
Okay,
Ok.
1, 2,
Deflate.
3.
so
Okay.
6, so we went 25. You went high pressure in the LED as well. Went 25 in the circumflex. We did a kissing balloon just to accommodate. You have to size the balloons according to the. Okay, it's going to be difficult. Okay,
Yeah.
okay.
Yes.
Yeah, I see in the circumflex maybe some extravasation
Yeah.
there.
Yes.
You need to have back the balloon there.
Os dois.
Okay,
And we can do protamine here.
yeah, and we're going to do the protamine. Leave there and try to advance the
Peraí.
balloon and leave there
Tirar pouquinho a
the
farinha.
balloon inflate a little bit. Not in the left main, not in the left main. A little bit more distal,
Vamos reverter a farina.
right?
Yes, the
Yeah.
protamine here you already asked for.
Okay. And patient stable, pressure stable. And we're gonna keep here. So I think, can I have the camera here with me now? Please remove the angel. Can I have the camera here now? Okay, me here. Okay, okay. So yeah, just have me here. Okay. So this case was, I would say, very challenging case. This was a case that a patient with 73 years old,
Reverteu. Bem,
first episode of chest pain was a week ago.
5.000.
Patient was in a flight. He came back to our country. He was have an additional clinical event,
5.000.
and after that he came to the ER of our hospital,
DA também.
and he was diagnosed with ACS unstable angina. He underwent yesterday with a diagnostic CAT, which demonstrated significant disease involving the mid LAD, also the left main bifurcation. This case was discussed, into the heart team environment. He has 23 syntax score. He was eligible for either revascularization methods, and we are being demonstrated here with IVUS and imaging guidance, angio-based imaging guidance. This procedure, which included first stent in the mid LAD, then we stented the left main circumflex with a nanocrush technique. So we have optimized this in the best way, and now we had the control angio. There's a bit of small extravasation at the body of the circumflex stent in the proximal part. Patient remained very stable, and now we're doing some prolonged balloon dilatation. So looks like by angio things are solved,
Yeah.
and maybe we can have a final control angio.
Yes.
We're
I'm
just
going to-
gonna
Yes, here. One.
can have the angel here, okay?
Okay.
Okay, so we have balloons there. Looks like a very acceptable result, right, Rodolfo?
Yes.
And I think this patient has all the possibility to evolve, in
Tem
the
mais?
positive way. So we do some extra balloon here. That's no instability, and just a bit more time to have a full sealing here of this part, but very stable and confident that everything's gonna be okay. So I think we will do some extra work here in terms of time, just to have everything sealed, do a final control IVUS and final control angel. We have been with you for more than 1 hour. Today we're going to have only this case to demonstrate. So with that, Rodolfo, I think we can already say, goodbye to our friends here, and hope to be together with you next week and bring two more interesting cases. So thank you so much. Thank you. Thank you.